I want to welcome you to Breakout Session A, that's Understanding Age-Related Macular Degeneration. So without further ado, Dr. Tom Sheidow.
Thanks, Sharon. It's almost embarrassing to come back up and speak to you, because an hour from now, you're going to realize how long-winded and loud-mouthed I am, because he just did in 2 minutes what I'm going to take an awful long time to do. It's embarrassing because some of my examples that I use in the clinic all the time just got taken from me, which is great. It's good to know that we're all explaining things in a similar way. What I'm hoping the next half hour and then half hour of questions will be is an opportunity to provide you with a little basic understanding. For those who don't have it, hopefully it'll at least get you off on the right foot. Those who already do, hopefully it'll at least explain my perspective on things. And most importantly, I guess, move us forward into a little more knowledge in the second session for those that are interested, or at least something you can take forward to the other talks later on today. And so really this is just an introduction to macular degeneration in general. Not just what it is, but why we care. Because I think it's important that we all get off on the right foot about what macular degeneration is and isn't. And in order to do that, Brian already started us in his talk with a bit of an explanation, but let's go back for a second and make sure we're all on the same page as far as what we're talking about. If you picture a camera, and just looking around the room, and I don't mean this time at familiar faces, I mean at the plethora of birthdays, most of us will remember cameras that had film. And cameras that had film had a lens, had a focusing mechanism, and in our eye, the lens and the focusing mechanism are called the cornea and the lens, and those structures have a specific purpose. The purpose is to focus the light on the light-sensitive tissue, the film at the back of the eye called the retina. And so really it is the retina that is the film. Without a retina, we see nothing. And with a damaged retina, we do not take a clear picture. And so it's the same thing as exposing the film to light too soon or too long. We don't get the ideal picture. More specifically, when we talk about the retina, or when we talk about the part of the retina that we deal with in macular degeneration, we're talking about the macula, and that's a very small area right in the center, and the dead center is called the fovea. And so if you hear the term macula and fovea, we're talking about that portion of the retina that does the most detailed work. It's like the bullseye of the target. That portion of the retina does all of our detailed reading, and that portion of the retina does our color vision. And so when we talk about the macula, we're really talking about a disease that takes away your ability to read, to make out fine details, not the ability to get down the hallway without bumping into people and objects. Macular degeneration and the macular processes in other conditions are responsible for your central vision. The other important thing moving forward, and again, Brian touched on this, and I'm going to as well, but specifically for macular degeneration, I think it's important that we understand a couple of those layers he was talking about. Because really this disease, when we talk about it, is a disease of the relationship between three different structures. You have the photoreceptors. Photoreceptors are called the rods and the cones. We all learned about them in high school. The rods and the cones are what actually see, but underneath the rods and the cones there is a pigment layer, properly called the retinal pigment epithelium, or RPE. But that pigment layer is really the workhorse. It's not the workhorse that sees, it's the workhorse that protects, supplies, and supports the photoreceptors. And so it provides an important aspect of our seeing as well. And then underneath the RPE is the layer called the choroid. It's a blood layer. It is not part of the retina, but it provides nutrients through that RPE to the retina. And the crack in the sidewalk example, if you saw it up on the screen, the crack comes from the choroid, and it is the ingrowth from that layer that we all dread when we talk about wet macular degeneration. And we'll come back to that. The video also mentioned drusen. And drusen are important because when we talk about diagnosing macular degeneration, that's what we're looking for when we look in your eyes. Drusen are simply areas at the back of your eye which we can see clinically when we look in with our microscope. And drusen represent collections of waste material. Whenever we make something, we produce waste material in all parts of our body. And in our retina, that waste material should be eaten and discarded by the pigment cells. But if those pigment cells are not healthy, if they cannot keep up to the process of reading, then what happens is some collections accumulate in our retina, and we get these yellow spots called drusen. And they look like little yellow droplets at the back of the eye. And so when we talk about macular degeneration and ask the question, what is macular degeneration? Macular degeneration is a process at the back of our eye. It is not a normal process. It is a disease. It is a disease because it's not supposed to happen. But in that process, what happens is these drusen and the pigment cells become damaged. And so what we're seeing, as opposed to normal aging, is an abnormal collection of drusen or waste material and a loss of the pigment cells. And so what we are seeing is a deterioration of the tissue. And how it differs from normal aging is that normal aging is not associated with losing vision. Anytime, please, any of you hear someone say, I'm 80, that's why I don't see well. The answer is that is not correct. Whether you are 80, 60, or 40, it is a disease that takes away your vision, not your age. All right? And it's important people think that way, because if you believe it's just because you're older, you are going to ignore the signs your body is giving you to get it fixed or get it looked at. So for a second, before we talk about age-related macular degeneration and all the things that we want to hear, what we should talk about is why we care. Why is it that this is a big problem to talk about? And the first thing to sort of go back is in 2008, the CNIB, the Canadian National Institute for the Blind, did a big survey and report. And in that report, they highlighted the 4 top reasons for visual loss in Canada: age-related macular degeneration, diabetic retinopathy, glaucoma, and cataracts. And if you look at those 4 diseases, the 4 most common, not only does macular degeneration top the list, but if you put together, now when I say register with the CNIB, anybody who is considered legally blind, and please understand what I call legally blind and what I call blind are 2 different things. Blind means you can't get down the hall and get around, to me. Legally blind means you can't read the letters on the chart. But if you look at people who have been registered with the CNIB, age-related macular degeneration accounts for more than 50%. Meaning if you take all other diseases of the eye, put them all together, they are still smaller in the production of blindness than that one disease called macular degeneration. And so it is a huge part of vision loss in Canada. The World Health Organization has labeled age-related macular degeneration the leading cause of blindness in the developed world. And it's specifically the developed world because in the underdeveloped third world countries, cataracts are still a massive problem. But in a country like Canada, the United States, Europe, all those places, it's macular degeneration. And why that's important is you hear about research, you hear about the efforts, the treatments, and everything else, but despite all these efforts, more people are going blind every year because of a lack of awareness, a lack of research, and because our population is aging. And as the population ages, more age-related problems accumulate. And so we are winning the battle in so many ways, and yet we are losing it in others. Macular degeneration itself is very prevalent. In the patients over the age of 50 or 55, it affects about 15%. But when you hit the age of 75 and greater, about 35%, 1 in 3 people, have age-related macular degeneration. And that amounts to about 180,000 New cases. That's not cases that have been around for a while. That's new cases of macular degeneration every year. And it's not meant to compare macular degeneration to these other diseases, but if you add up all the people affected by Alzheimer's, Parkinson's, breast cancer, and prostate cancer, 4 conditions that are exceptionally well known, put all the numbers together, macular degeneration is still more. We're not comparing the effects on the individual, but the prevalence, the number of people who are affected by this disease is huge. And it's important because one of the most important things in treating a disease is raising the ability or providing patients with the ability and raising the awareness of the disease. Because if people are unaware of the disease, they cannot know the symptoms which they should look for in order to seek out care. And so one of the biggest hurdles we have faced over the last 12 years, and I say 12 years because really macular degeneration has come to the forefront since about 2001. One of the biggest hurdles has been getting people to get themselves seen. 80% of Canadians were aware of what macular degeneration was, and despite this, about 31%, 1 in 3, go once every 5 years for their annual checkup. It's not a very good number. Half of people who don't wear glasses haven't even seen an optometrist or an ophthalmologist in the last 5 years. And 60% of people over 65 don't go for their yearly checkup even though it's covered. And so it sort of highlights the fact that we are our own worst enemies in many ways. Going for an annual checkup can help at least pick up a condition which we should be all worried about. So the next question is it obviously affects a lot of people. What is the impact? Well, if you take a group of older individuals with macular degeneration and look at what they are at risk for, and I don't mean visually, I mean what other things. People with macular degeneration are twice as likely to express difficulties just living daily life. Tasks that require vision are harder to do. People with macular degeneration are twice as likely to sustain a fall. And I probably don't need to tell the people in this room what a significant fall can do with respect to broken hips, etc. It triples the risk of depression. It is well-known association between depression and macular degeneration. And it quadruples the risk of hip fractures. It is other than just in the eye that macular degeneration has its effect. It also hits us in our pocketbooks, every one of us, because the cost of macular degeneration is estimated in Canada to be around $7.9 billion. Now that's a combination of two things. It's a portion of money which is spent on health care by the governments for treatments, evaluations, examinations, etc. And it's also the indirect cost, because it certainly is no secret to me in my clinic, almost nobody comes by themselves. You are not coming to get a needle in the eye and driving yourself home. And many of the people can't drive anyway. And so there are indirect costs we talk about in that there is someone else affected, someone else who is bringing the patient. And so if you look at that, that is a huge cost to our society. So moving on to macular degeneration specifically, the question is, who's at risk? How do we pick up these people and what do we do? And I like to break the groups down into two types. You've got your group of risk factors that you can't change, and you've got your group of factors that you can. In the group of factors that you can't change how old you are. If you figure it out, let me know. You can't change your genetics, at least not yet. And in the foreseeable future, that's not going to change either. Your mother and father are who they are, and hence they provide you with a risk or a benefit from macular degeneration. You can't change if you're a male or a female, at least not genetically. And so the belief that women get macular degeneration more than men, there's a lot of, I would say, argument about that fact. Many of us believe that's because women live longer, and if age is the big risk, maybe gender is not a big risk, but nonetheless, It appears to have some influence. And your race. Certain races have a higher impact of macular degeneration than others. So those are the things you can't change. The number one thing you can change, and our society is pushing towards it, but still hasn't eliminated it, is smoking. Smoking, I know we all know about the harm with lung cancer, asthma, emphysema, but smoking absolutely, positively, without a doubt, we can argue it till I'm blue in the face, is the number one avoidable risk factor for macular degeneration and the progression to vision loss. The second thing being our nutritional health. And we'll talk a little bit more about that, and there's a whole session on that later on today. With respect to some of these, great studies were done through the 80s and 90s looking, and the age factor is by far and away the highest risk. In what was called the Beaver Dam study, they took a large group of people. They followed them through the ages, and they showed that by the time you hit 70 plus, fully 25% or more of people, and that number goes up when you hit 80 and 85 and 90, suffer from macular degeneration. And there is no point at which that risk goes away. And I already mentioned that smoking is the only avoidable risk factor. Smoking is felt to triple or quadruple your risk of progression to significant macular degeneration. And that's because, although we don't know the specifics of how it works, smoking has an impact on the blood vessels, and there is a need for nutrients to get to your unhealthy pigment cells. And so there is some kind of a tie between your blood vessels and smoking and the progression of macular degeneration. But that is an absolutely well-proven statistic. I'm going to try every now and then to throw out some of the questions I expect to hear in hopes of having the chance to answer some ahead of time, but you may still have questions based on my questions. Confuse you more than I help. One of the first things is, does cataract surgery increase my risk of age-related macular degeneration, or AMD? And there's a lot of controversy with respect to this. I would say at the present time, it is absolutely not clear that cataract surgery does put you at risk. And one of the ways you want to look at that is that cataract surgery is like death and taxes. It will occur if you live long enough to get them. If you have a common problem like cataract and you have a common problem like macular degeneration, it is not uncommon that the two will coexist. One of the reasons many people come in after their cataract surgery with a new problem is because prior to it, they took the time to blame their vision loss on getting older and having a cataract, instead of seeking out help and seeing that it was actually the macular degeneration, not the cataract, that was causing their problem. And so after they have the cataract off, they have this wonderful belief that they're going to see well, only to find out, lo and behold, they were incorrect, that the problem wasn't fixed, that it was the problem at the back of their eye. And so I think there is a sudden realization of macular degeneration, not a sudden onset of macular degeneration after cataract surgery. That is my belief. There is no clear-cut evidence in the literature to say that that is true. Sun exposure has long been looked at, and there are many, many large group studies trying to look at this question. And without telling you the pros and cons of each study, the answer is we have no idea. If it was clear-cut, these studies would have clearly shown that sun exposure would increase your risk, and that has not been proven to be the case in every study. And so at this point in time, I think there is some merit to wearing sunglasses, especially in a group of people who have macular degeneration, but it's more a functional benefit. In my patients with macular degeneration, there is no doubt that if you send them out on a nice sunny day like we have today, ask them to come back and read the same thing they were reading before they went out, they can't do it. People with macular degeneration, their retinas are stressed. They are barely keeping up with what they want to do, and if you blind them with bright lights, even temporarily, it takes them a long time to recover. And so sun exposure is a harm in the sense of enjoying your vision, that's for sure. And sunglasses are a wonderful way of protecting that. I tell my patients, put them on before you go out and take them off after you come in. You don't want to walk out, be blasted by sunlight, put your glasses on and think that you're protected. You've already had the blast. And so wearing a pair of sunglasses is excellent for using the vision you have. Will it prevent macular degeneration? The verdict is absolutely out. One thing that has changed with respect to risks is the whole genetic aspect of it. If you'd asked me 10 years ago, the answer was we really believe there's a genetic component because parents who have macular degeneration certainly have kids who get macular degeneration. And so the association was obvious in that sense, but there was no proof. And over the last few years, it's become quite clear that although there's not one gene, unlike some of the conditions that Brian was mentioning earlier today, there is not one thing to fix, but there are several things that have clearly been shown to be associated with a higher risk of developing bad macular degeneration. One of those things is felt to account for about 50% of it. And so what's interesting now is that there is a genetic test available. I'll tell you my bias, and it is truly my bias on its role. But what that genetic test does is it doesn't look at one aspect or one gene. It looks at your risk based upon several genes and says, what is the likelihood of you getting a significant amount of macular degeneration? But it is not able to predict you will or you won't. And so for most of the people in this room who already know they have macular degeneration, there is absolutely no benefit to having a genetic test that tells you what you already know. You have macular degeneration. And it is also not a fail-safe to take someone who is 20 or 30 who has parents and grandparents and test them. Because until we know what each gene means, and until we have a therapy for any one of those genes, at the present time, there isn't anything we can do with the information. And so what I would say is you go back to the first premise, and that's we should be having our annual eye checkups. We should be watching for a disease that can blind us, and we should be moving forward in a preventative way as best we can. This topic of nutrition I'm going to touch on briefly because it's sort of part of an Understanding AMD talk. There's a longer portion to it later on in the third breakout session today. But you can't talk about macular degeneration without talking about what I would call the ARED study, the Age-Related Eye Disease Study. It was a study in which the National Eye Institute, which is a United States organization who is a wonderful funder of eye research, funded 3,600 patients to be watched for 5 years and to determine whether there was a benefit to giving them vitamins and antioxidants to slow down or prevent macular degeneration. Before that, what was happening was everybody was telling you it was a benefit. How many people were told to eat their carrots when they were a kid because it helped you see better? There was no proof of that. It was completely an old wives' tale. And yet we all perpetuated it, but this study proved to some degree it was true. But what you need to understand, and I think that it's some misinformation that is still out there, is what it proved. One of the very clear things from the first ARED study was the vitamins and the antioxidants were necessary. Neither one on their own did any good. And so if you're going to take vitamins, you must take the antioxidants. And if you're going to take antioxidants, you've got to take the vitamins. If you're not going to do both, you're not doing anything for yourself. Study has shown that 100%. It is also shown that this does not prevent macular degeneration. It slows it down. You are not curing your disease. So don't take it expecting to see better. That's important. Because if you start on macular degeneration vitamins, and then you say, well, I'm not seeing any better, I guess I better stop them, they're not helping me, someone didn't inform you right. Those vitamins are for life, and those vitamins are there so that 10 years down the road, 5 years down the road, like the people in the study, you will have less macular degeneration than you would have had you not taken them. And so it's important you take both, vitamins and antioxidants. The vitamin supplementation reduced the risk of progression by about 25%, a statistically significant amount. And it was clinically significant, which means it matters to you, not just to the mathematician looking at the study. It did not do any good to take one component, and it was a vitamin that in the study was taken in addition to any multivitamin people were already taking. And so if you're on a once-a-day vitamin, whatever that is, it has shown that taking the AREDS vitamin on top of that is still of help in macular degeneration patients. Now, one of the questions that came up right after AREDS was, well, what about lutein? What about lutein? And there's where one of the misconceptions, and I would say was perpetuated by some of my eye care professional colleagues, is that lutein was more important than the vitamins. We didn't know that. There was no proof of that. Why throw the baby out with the bathwater? Lutein is a pigment that we all have in our retinas in a very high concentration in our macula. Makes sense, I agree. But you don't throw away something that's been proven to help for something that hasn't. There was some small studies and some bigger studies that said lutein will help. But the point being, why replace one with the other? And this problem became so big that there was an AREDS 2. And Dr. Iordanis will talk more about AREDS 2 later. But suffice to say that at the time of AREDS 1, lutein could not be produced and supplemented. If I can't give it to you to take, we can't study it. And so that's why it wasn't in the first study. Lutein absorbs UV light, and so the theory by why it would help makes sense. And there's also the idea of fish oils. I think everybody's heard how good the omega-3 fish oils are for their bodies and for their eyes. And so when AREDS 2 was started, they took what we knew, AREDS vitamins, and they compared that to lutein, and they compared it to the fish oils. And they said, does this help? Are these as good? Can we replace? Lots of questions were asked. They also tried to answer some questions about zinc, because zinc is in the antioxidant group, and zinc upsets people's stomach. Could we lower the dose of zinc? And at the end of it all, I think the important outcomes of the AREDS 2, and that came out this spring, was that lutein offered no additional benefit over AREDS vitamins. You can't replace AREDS by lutein and think you're doing something better. They're the same. But it was clear-cut that adding lutein to AREDS, in addition to, not instead of, made an additional benefit to the patients. And so at the present time, I encourage all my macular degeneration patients to take AREDS with lutein, because lutein is helpful. One of the other things, and I don't want to spoil too much of Yanni's thunder, but one of the other things that came out, and this is the reason why I really dislike the throw the baby out with the bathwater, beta-carotene and lutein come from the same family. They are both what we call carotenoids. And if you assume that the body deals with them in a similar way, they compete. And the question is, will they work what we call synergistically? Will they work together? Or will they work against each other in ways such that one affects the use of the other? And one of the things that the AREDS 2 study showed was that, yes, beta-carotene works against the benefit of lutein. And so, in fact, what we should be doing is taking the beta-carotene out of the original AREDS, but keeping AREDS and putting lutein in instead. And so it has really reshaped things. One thing I tell people is there is lots of different products out there. Almost none of them have ever been tested. And I don't mean because it will do a harm to you. It's because there is no proof that they help. You probably do more good putting your money towards the Foundation Fighting Blindness as a plug than you do buying those vitamins. There has never been any studies with other things. So be careful what you spend your money on. If we're going to talk about macular degeneration, I think it's important to talk about what happens if you don't do anything. Macular degeneration untreated. So if we go back to the 90s and the 80s, almost never I say almost because there is a very, very small hand group of people in my practice, probably not in most people's practices, who will, but never leads to total blindness. Macular degeneration patients don't fall under the same group as our hereditary colleagues who lose their peripheral vision. Okay? It is a disease of the central function and only of the central function. It is detected by a clinical examination in your optometrist's office. There is no special testing that needs to be done. Special testing is required when the degree of the disease necessitates further evaluation to see if other interventions are needed. And so the chain usually goes, you go in for a checkup once a year. The optometrist sees drusen, pigment changes, tells you have macular degeneration. At this point in time, if wet disease is suspected, and I'll talk about dry and wet in a minute, you're passed on to someone like me, at which point tests are necessary to determine if treatment is available and if there's anything we can do. The biggest delay in care is you. The biggest delay in care is having someone notice the problem or let us know about the problem. And the only way to know if there's a problem is to take the time to check. And it's not whether you can read the newspaper. It's whether your right eye can read the newspaper and whether your left eye can read the newspaper, because we are all wonderfully blessed to have two eyes and a brain that can take whatever information is given and use it to the best of its ability. Our brains will make that distinction, and we will ignore a problem. Dry macular degeneration produces a very slow deterioration in our vision. And typically, when we talk about dry, we're talking about the process where there's an increased accumulation of drusen and RPE changes. And that change affects about 85% of people with macular degeneration. If the deterioration is going to go on, you will see a loss of central vision, and with dry, you never, ever, ever lose peripheral vision. If you ask what the risk of progression is, about 5% or 1 in 20 people who have dry will go on to what we call legal blindness. And if they are going to go to that point, it takes about 10 years or more to get to that point with dry degeneration alone. And the key, as I said, is the simple test of whether you're looking at an Amsler grid, which is a piece of graph paper, looking at your vertical blinds, looking at the door frames, one eye at a time, once a week. If you see a problem, get it checked. Low vision aids, things that are available either at specific low vision clinics, at the CNIB, some of them are sitting out here to show you devices today, are very helpful in people with dry degeneration. And in many patients, a low vision assessment is very, very worthwhile. The film touched on wet, and what happens in wet degeneration is that barrier layer, the pigment cell, gets cracks. It was a great example, the cracks in the sidewalk. And what happens is, through the crack, a blood vessel will grow like a weed grows in the sidewalk. And it is that blood vessel that grows up that starts to leak and bleed. It is the blood and fluid which do the damage. If left alone, that blood vessel turns into a scar, and at the present time there is absolutely no treatment for scars. And therein lies the difficulty and the necessity to get checked. You have to get in and get it before it is a scar, or the treatments we have limits and limited benefits. Wet is very different than dry because, as opposed to dry, where very few people lose all their central vision, wet is almost always going to result in total loss of central vision. It almost always will lead to what we call legal blindness, and that blindness will occur over the matter of weeks or months, not years. The worst part about it is, if you have wet in one eye of any type and you flip a coin, heads you win, tails you lose. That's how often it comes in the other eye. 50% of people who get wet in one eye get wet in the other. And so it is for the wet people that we have to be concerned about testing, and there are two tests that I want to highlight a little bit in the background part of macular degeneration. One being called a Fluorescein Angiogram. We put a little orange dye in your hand. It is not iodine. We snap photographs, not x-rays, and that is the test to confirm wet or dry. It is not used to follow patients nearly like we used to, but it is necessary at the beginning. and it helps guide our therapy to some degree. It determines the location and the type of blood vessels and is generally considered an exceptionally safe test. It is not like contrast used for X-rays. An OCT, or an optical coherence tomography, is a newer test. It has certainly been around now for about 15 years. It actually can confirm the fluid, but most importantly, it can also tell us exactly how much is there. It has now gotten to the point where, although once upon a time I believed I could see the fluid that was there, I now must rely on the OCT because I realize what I can't see, the detail of what's there. And an OCT will allow us to fully treat and pick up early recurrences. And so it's the OCT that really does guide our therapy. One thing I want to point out to you, and it's specific to Ontario, I can't speak to other provinces, but fluorescein angiography and optical coherence tomography are entirely covered by the OHIP system. There are no tests required in my office for macular degeneration that you have to pay for. Fluorescein diagnosis, OCT follows, and those are covered. We can quibble over the differences. I might want to do more OCTs than the government will let you have, but I cannot charge you for an OCT. That is illegal and is called extra billing. So whether you get 4 tests like the government wants or 6, it's between me and the hospital, not between me and you. Furthermore, there are no other tests which are more better at picking up macular degeneration that aren't covered by OHIP. So watch that you aren't doing tests at exceptional cost to you that are not necessary. Just to touch in my last 2 minutes on some history, because in the next session I'm going to talk about where we are now. Historically, we did have a laser, and it was like a jackhammer. Lasers do one thing, they burn. And what they burn and destroy. It was a great tool for a very small number of people, the small number in whom had a small blood vessel well away from center. Laser is now used almost not at all in our practices. The real advent, the real first step forward, the real game changer came in 2001 when Visidyne came along. A drug that went in your veins, ran around your body for 15 minutes that we turned on with a laser, a cold laser that didn't burn your retina. That drug did require an infusion. It did require a nurse. We did get through it, and it was able to limit the vision loss. It was the first thing we had to treat blood vessels under center. It was the first ability to limit the severe losses that were happening to our patients. But understand what we were doing is limiting loss. We were talking about slowing it down, and it worked well. But now what's happened, and it happened in 2005, 6, 7, what we were fortunate enough to get was a new era, what I call the dawn of the day of angiogenesis. And angiogenesis is a big word to talk about blood vessels growing. We need blood vessels to grow all through our body. Without blood vessels, we die. Without blood vessels, we can't heal tissue. But all blood vessel growth is not normal and not healthy. And in the eye, at least in this problem, angiogenesis or blood vessel growth is harmful to our vision. And so what came along was something called an anti-angiogenic, something which attacks blood vessels growing. And the first company that came out with something was called Macugen by Pfizer. And it was really a leap. It was an astronomical leap to think we could put a medicine in the eye and stop this growth factor called VEGF from growing blood vessels. The drug didn't work any better than Visidyne, but the concept was phenomenal. So phenomenal, in fact, that the next drug that came along was put on the cover of Science magazine. Eye drugs don't get the cover of Science magazine. This one did, and it was called Lucentis. And Lucentis was really the game changer in the last few years because all of a sudden we had a drug that wasn't going to limit vision loss. It was exceptional at stopping vision loss, and it gave a group of people a chance of recovering some of the vision they've lost. So in general, when I start somebody on Lucentis, I can tell the patient, on average, 100 people in the room, on average, you will gain vision. Does that mean you as an individual will? No. That's the problem with statistics. They don't predict people, they predict groups. But this was the first drug that actually offered the hope of getting back some of the vision you've lost. And that hope was well founded in 2 good studies published in the New England Journal of Medicine. About 35 to 40% of people were getting back 2, 3, 4 lines of vision. Now you could turn that around and say that 2/3 of people weren't getting back 2, 3, 4 lines of vision. But it was a start. It also improved people's quality of life. The studies did other aspects. They looked at, well, what does it do to Joe or Joan's daily life? And the answer was, it makes it better. And that's the goal here, to make life better. It doesn't matter if you gain 1 line or 3 lines. It matters if we make your life better to do the tasks you want to do. And because most of the gain in vision occurred in the first 3 months, the appropriate clinical practice and use of Visidyne is to give a needle once a month. And yes, as Brian mentioned, it's a needle in the eye. Might as well get over that fact right away, because for the foreseeable future, that's all we have coming. It's a needle in the eye once a month to achieve as much vision as we can, and from that point forward, we'll talk in our next talk. I'm going to sort of end it there. What it has done to our practices and to your lives is it has created a clinic of giving needles. It is a huge, huge change in practice. And for anybody who was with me 10 years ago and is still with me, they have seen a huge change in the way the clinic runs, out of necessity. One of the things I said last night when we were talking is it's a phenomenal thing to me to look back 5 to 7 years and at some of the patients I'm still seeing today, some of them are in the audience and they know who they are, who are still getting a regular needle. But they're still seeing better than the day we met. And that's a good feeling for both of us. If I had asked them then, do you envision seeing me on a regular basis for the rest of your life and getting a needle stuck in your eye? They would have run out the door. If you ask them now, they are thankful for the discovery of the drug, and they put up with a lot of problems in my clinic in order to get the drug and the needle in the eye that, we don't want, but we need. There are new things coming. We'll talk a little bit more about how we use Lucentis and the new things coming this afternoon. But what I'd like to do is end it there and open the floor up to questions. Thank you.
I've been told that if you have AMD and cataracts, and it becomes a necessity to have the cataracts removed, in all probability you will end up with the wet.
You've been mistold. It's the simplest answer. Wet can develop whether you have cataract surgery or not. My argument would be never have the cataract done before the cataract is affecting your vision. That's the hard decision. When is it the cataract and when is it the macular degeneration? If the cataract is the problem and the macular degeneration, but the cataract is significant, take the fixable problem and fix it. Why live with something which is fixable? The hard decision is how much goes to which. But absolutely not. If that was the case, as I said, everybody in this room that lives long enough will need cataract surgery. If 1 in 3 people in this room has macular degeneration, 1 in 3 would have wet macular degeneration because everybody gets cataracts. The numbers would say 90% dry, 10% wet. It doesn't work. Cataract surgery does not turn it wet. Yes.
I have 2 questions. You said about the Eris vitamins and things. Is that the only thing that we can do for dry macular degeneration?
I guess only in the sense of only thing that has been proven to help that you can do for yourself. I think that I would lump together regular checkups as something you're actively doing for yourself. Right. And so I would encourage everybody, get to know your optometrist, make sure it's the same person every year or every 6 months. you want to have a consistent person, like you have a consistent family doctor. That relationship is important. Another thing you can do for yourself is low vision programs. Low vision programs if you have stuff that cannot be treated, or if you need a boost for reading or doing some of the daily tasks. And so it really may sound like a bit of a crutch, but those are services you can seek out and get some help from. But there isn't anything else you can actively do to take and slow down the disease.
The second question was sensitivity to things that might decrease the absorption of vitamins. Have you heard of anything like that?
I think that would be sort of along the lines of what I was saying about the beta-carotene and the lutein. What we do know is that although we all have this positive feeling about vitamins, vitamins are good for us. There is also vitamins which in too much are harmful to us. Some of those vitamins can be taken in high enough doses that they are harmful to our health. And that's where you want to be careful that more of a good thing doesn't make it better. And as far as sensitizing, I can't say any specifics, but there are things that certainly do affect absorption, and there are other diseases that affect absorption. Many of the bowel diseases that people suffer from prevent them from absorbing vitamins in an ideal way. And so certain formulations may be more amenable to a certain person, but that is beyond my knowledge as far as what the gastroenterologist would say is the best best form of vitamin to absorb. She's coming.
Are there any studies or trials going on now in the London area that a person could become involved in?
There's nothing right now for dry macular degeneration. There are some, and I'll talk about them in the next sort of session as far as the wet. It's one of those things that you have to often be deemed eligible and, more importantly, be new to get involved with. And what I mean by new is people who are currently under treatment often are not eligible for new treatments.
Retina. Is a folded retina a byproduct of AMD wet?
No.
Have you ever heard of that?
No, folds in the retina. I mean, the retina can look folded because of a scar. And so we all use different examples. I mean, I actually use the crack in the sidewalk example. There's different ways to explain things to patients. I use the word scar in macular degeneration. Someone else may have called it folded, but at the end of the day, scar tissue and debris in the retina after wet, it can look like a fold, but a true fold of the retina doesn't come from macular degeneration. I would say it comes more from retinal detachments and things like that. But I suspect what you're asking, the answer should be yes, because when I talk about scarring, sometimes a scar is a lumpy, bumpy, wavy change at the back of the eye, and that may be what your optometrist or ophthalmologist is saying, folded.
Well, it was I supposedly had one good eye, and I had this gray line come up, and I thought it was a cataract. And I went back and had it checked, and he said, no, there's a fold in the retina.
That may also be a separate problem called an epiretinal membrane. It's not, again, a fold in the retina, but it's a bit of scar tissue on the surface that is puckering the retina and distorting it, and that can be removed.
Okay.
But I'm surmising a lot here.
Thank you.
My question is about the vitamins. You mentioned earlier with the progression of the vitamin study with the ARIDs and then when they added lutein, and at the end you mentioned the omega-3s. Was there a recent study that looked at including omega-3s, and were those studies, were they effective or beneficial in slowing the progression of AMD?
And the answer is I was surprised, but the answer, stealing some more of Yanni's thunder, was absolutely doesn't help. If you need the omega-3 fish oils for your general health, for your heart, whatever, take them. But as far as the eye goes, there is no additional benefit to taking the fish oils. And so I've now started recommending that you go back to the regular product only because the addition of the fish oils adds a significant cost to the product. It is not because I think they're harmful. In fact, they aren't, but they were in that AREDS 2 study, and it did not show any additional benefit as lutein did. And so the recommendation has been that I neither encourage nor discourage the use of the fish oils.
Do you still advocate or recommend taking 2 of the vitamins per day?
It depends on which company's vitamin you buy. What I usually tell people, or I have a little sheet I give people with the doses, and the important thing is to whatever vitamin you choose to take, whatever company you support, make sure you get the right amount based upon the study. One company it's 2, one company it's 4, sometimes there's an extended release. It's hard to say exactly, but it isn't always what's written on the bottle because there are rules on how vitamins can be sold to patients because they're over the counter.
Okay.
So you want to actually get the dose and compare.
Okay,
Thank you.